thanks very much again, Dr. Chauhan sir, for inviting me. So coming to the topic of the discussion this evening, we all know what a problematic situation we can have with hypertensives across the spectrum for our patients, and we do deal with those patients day in and day out. And there is a very interesting perspective which is now coming up in terms of nutraceutical and micronutrient management of hypertension, and how things can be modified apart from the drugs in terms of nutraceutical and micronutrient management, in terms of we're looking at the compositions of various formulations which can help the patient in a very non-side effect kind of a manner. So to take the entire thing forward, it's my huge pleasure to invite Dr. Viveka Kumar to make this presentation about micronutrients like magnesium and other formulations which are there, and we'll be discussing this during the course of the event. And Dr. Viveka Kumar is a very, very close friend of all of us, and he really doesn't need any introduction. He has been introduced umpteen number of times. Suffice it to say, he is one of the most dynamic cardiologists that we have in the city, and always accessible to each one of us at any point in time during the day, so which is huge. And may I invite Dr. Viveka Kumar to make his presentation and take the CME forward, and after that we could put down the queries and comments together. Thank you very much.
Well, so good evening friends, and at the outset I think we must thank Pharmic for making this evening possible, and Dr. Chauhan for keeping faith in this molecule to decrease the blood pressure, and we must thank Mr. Manish for bringing a new dimension in management of hypertension, where we have always been discussing about how antihypertensive things would work, but can micronutrients and all would work in this situation? The answer is definitely yes, because after the lifestyle we have gone into the realm of antihypertensive medications. But let's see, because at one point in time there are many, when we get so they are basically focusing on the magnesium molecule with this salt, and when we have been seeing patients who come to cardiac arrhythmia, and those who have got instant ventricular fibrillation, ventricular tachycardia, in those situations when all the antiarrhythmics do not work, then we say that better to give magnesium injections and correct the magnesium level and all that, so that it becomes the VT storms, they are easier to be treated. Though probably they might have got a leave out of that practice. So if you see the burden of hypertension, that's quite humongous. 35% of the world population are affected with hypertension, and the way the life is going on, definitely more and more people would have, at a much younger age, hypertension is going to affect. The challenges in current therapy is that we know that there are limitations. There are a lot of the gaps in this therapy, because we are not yet able to conquer that, and the problem is increasing. Though the answers has not increased, but the problem is increasing, and 1 in 5 people is having high blood pressure, and you would also know that more than 1 in 5 people are Indians. So definitely the Indians are the ones, and by 2025 India is going to be more populous than China, and the problem is that most of our population, by 60%, would have hypertension. So that's a very, very grim situation, and we say that hypertension and diabetes are the commonest cause for coronary artery disease and the stroke. So we need to tame this menace, so that we don't really get into high what we call cardiac mortality and the stroke disability also. So the current challenges are that nearly 80% of the hypertensive patients are not able to achieve adequate blood pressure control, and the only 2/3 of the hypertensive individuals cannot be controlled on one drug, so we need multiple drugs, and this has been now validated by not only the ESC guidelines also, but ACC-AHA guideline also, and the Indian Hypertensive Society also. So it has been well recognized that the combination therapy, or what we call more than one pill, is required most of the cases to control the blood pressure. So monotherapy and combination therapy cannot control the blood pressure in many hypertensives, and drug dose frequently leads to a substantial increase in drug-related side effects also. There are many patients who would not tolerate many of these drugs. They would have various kind of side effects, and uncontrolled hypertension is the real culprit. So what happens that uncontrolled hypertension will increase the risk of resistant hypertension, adverse cardiovascular event, and the morbidity and mortality. So as I said, hypertension is the commonest cause of adverse cardiovascular outcomes, and what it does, end of the day, 33% patients will have not well controlled blood pressure. They would land in heart failure. 69% would have cardiovascular death, almost 70% would have angina, and 73% of them would have mitral infarction. So till now, the current antihypertensive, broadly we say that ACE inhibitors, alpha blockers, and ARBs. B stands for beta blocker, and now the new guidelines of has really said that beta blocker should not be the front line of antihypertensive management, because unless they have got coronary artery disease. Then calcium channel blocker is a very, very strong pillar of the antihypertensive management, and diuretics have been. But the diuretics are good in preventing the stroke, and in elderly population it is really good, but obviously has the problem of electrolyte imbalance. Then we have got ACE and ARBs, beta blockers, all these things are there, but the problem is that each one has got a lot of side effects. Right from ACE inhibitor, where the cough and other problem would be there. So there is an importance of nutritional intervention in hypertension management, and that's what we were saying, that nutrition and lifestyle has got a very strong role to play. So use of nutritional therapy to control the blood pressure is something which is being considered to be very, very important aspect, and magnesium is a critical option in hypertension management. It's not really been studied till some time back very extensively. It is an important mineral which is found in the body and serves as a cofactor in enzymatic reaction responsible for regulating the blood pressure, and low intake of magnesium often predisposes to high prevalence of magnesium deficiency. And we have seen that because of the patients who are on diuretics and all, there the magnesium goes even lower, and we have seen that the patients who, as I was saying, that patients who have got low ejection fraction, a lot of them would have cardiac arrhythmias. They go into what we call VT storm, and in those situations we need to give magnesium intravenously 2 grams in 24 hours, so that these can be supplemented and the arrhythmia burden goes down. So magnesium is abundant, but magnesium is mostly found in intracellular. Serum level is 0.76 to 1.15, and is the average level. It is something which is important for vascular smooth muscle cell, and therefrom the hypothesis of interplaying with magnesium for control of high blood pressure comes, because if the vascular smooth muscle cell is involved, then if you act on this, then probably the blood pressure control would be better. So subclinical management of magnesium deficiency, if you recognize it well, if you get it detected and diagnosed, then obviously you treat it and the outcomes will be really satisfactory. So subclinical magnesium deficiency, serum magnesium does not reflect intracellular magnesium. So what happens that we are very commonly would do sodium and potassium levels in our patients who are feeling fatigue, those who do not have feeling weakness and all, those who are on diuretics, those who have got arrhythmias, we say that okay, check sodium, check potassium. We don't pay the similar attention to other electrolytes, especially the magnesium. So how do you look at the magnesium deficiency? This will also be the reason why it goes missed most of the time, is that it's a very, very subtle sign. There will be patients who are having fatigue and weakness, irritability, lack of sleep would be there, muscle cramps and headaches would be there, and poor memory, insulin resistance, unregulated blood pressure. So this is something which is important, and abnormal heart function, and they will have bone pain and osteoporosis also, but it's not really been documented and practiced widely. So subclinical magnesium deficiency would also lead to cardiovascular risk, increase in hypertension, atherosclerosis, and arrhythmias, as I was saying, that it's been in electrophysiology parlance. Magnesium is long back was recognized as an important molecule next to potassium to decrease the cardiac arrhythmia burden. And coronary artery disease, as a consequence of all these things, would add there. And then eventually, final common pathway of all cardiovascular diseases, heart failure, so definitely they would have. And then what it does is that it also increases the risk of platelet aggregation, eventually leading to myocardial infarction and stroke. So sudden cardiac death would be the something which is very, very important in this cascade. So if you see the subclinical magnesium deficiency, uncontrolled hypertension would be there one of the manifestation of uncontrolled magnesium. So magnesium as an anti-hypertensive mechanism is something which is important and which is something which is new. And let's see, when Dr. Chauhan called me that this is something which is coming up, so I said that we don't really have much data to prove it, but let's see how does it fare. So if you see the magnesium, which is a calcium antagonist, and we always give calcium channel blockers to control the blood pressure. So what it does is that intracellular magnesium inhibits the calcium function inside the vascular smooth muscle cells. So magnesium physiological calcium channel blocker responsible for muscle relaxation. So you need to play with these properties. So what it does is that vascular and endothelial mechanisms are there. It decreases the vascular resistance. It also increases the capacitance function, and not only in the peripheral artery, but also renal coronary artery and the cerebral blood vessels, and improves the blood flow. So these are the things which will, also the nitric oxide level increases, CGMP increases, cyclooxygenase system. So definitely these properties excites us that probably it will have some significant role. And magnesium and renin angiotensin aldosterone system is also interconnected. If you see the magnesium role in RAS, there is a decreased aldosterone production by inhibiting the cellular calcium influx in calcium dependent process, and decrease in plasma renin activity. So this is something which increases the blood pressure, angiotensin 2 level, and the cortisol level will also go down. So all these things which raises the blood pressure can be brought down and would work in favor of controlling the blood pressure. So decreased magnesium level would lead to dysfunctional regulation to vascular endothelial adaptive immune process. So there will be increased arterial stiffness, and also the vascular stress will go significantly up. So other thing which magnesium can do is that there is a catalytic function in the ADCY cycle, and it is essential for catalytic action on acetylcholine, and also necessary for keeping the catecholamines from adrenal gland in the check. So definitely these are the molecules which add to increasing blood pressure. So when you add magnesium, what you do is that you increase the endothelial dysfunction becomes better, the catecholamine sensitivity becomes better, then oxidative stress will become better, and arterial stiffness will become better. So eventually, if you are treating the decreased magnesium level, the blood pressure would become much better. So there will be structural changes which will lead to positive outcomes. So what does the magnesium do? Eventually, it reduces the blood pressure by decreasing the peripheral vascular resistance. That's the the subclinical magnesium deficiency also leads to sodium potassium ATPase dysfunction, and thereby sustained vasoconstriction. And vasoconstriction is the predominant mechanism by which any hypertensive causes would be there. So there are a lot of molecules which can cause all these inflammatory markers and all. During COVID time also, these interleukins and all, they were the cause of high blood pressure by virtue of increasing the markers or the molecules which causes vasoconstriction. So if you supplement magnesium, you are eventually improving the smooth muscle function of and then what it does is that it lowers the blood pressure, and eventually, so the SMD leads to continuous constriction of the blood vessel leading to hypertension. And when you supplement magnesium, the this thing does not happen. And more importantly, we have been seeing, especially in Indian patients, those who have chronic kidney disease, we see a lot of them would have very high calcium in the vascular wall. That the postulation is that magnesium supplement would also decrease the vascular stiffness and also the vascular calcification. So that will be a very important boon in disguise for our patients who are suffering from coronary on this magnesium management for the hypertension. So of late we have got a lot of data that effectively prescribed oral magnesium therapy for hypertension. It is something which has shown that normotensive do not show a blood pressure lowering effect with oral magnesium therapy, but oral magnesium therapy safely lowers the blood pressure in uncontrolled hypertensive patient taking antihypertensive medication. So it can be used as an add-on therapy or also in stage 1 or stage 2 hypertension. So if you see the data, there are pooled analysis of 7 randomized controlled trials. Systolic blood pressure decreases by almost 6 millimeters of mercury and diastolic by nearly 3 millimeters of mercury. So that's a fairly good decrease with the supplement of magnesium. And changes in the blood pressure and hemodynamic parameters are after oral magnesium supplementation in patient with essential hypertension. If you see the intervention data, that also says that if you do that, the diastolic blood pressure goes down by nearly 6 millimeters and systolic by almost 10 millimeters to 13 millimeters of mercury. So these things which also shows that the cardiac work index improves and also the systemic vascular resistance goes down, and observed hemodynamic changes explain lowering of the blood pressure with the magnesium therapy. So eventually it does the same thing which is done by any other antihypertensive agents, but this is something working with the different mechanism. So meaning thereby that if you supplement that, the magnesium in patients who have got subclinical magnesium deficiency, then they are the ones subset who are going to benefit. So the supplementation on the blood pressure in the patient, we have also the 34 trials improving 2,000, nearly 3,000 patient participant magnesium supplementation at the dose of 368 milligrams per day for duration of 3 months, decreases in systolic blood pressure, and also magnesium supplementation with dose of 300 milligrams per day for duration of 1 month is sufficient, quite sufficient to elevate serum magnesium and reduce the blood pressure. So dose response relationship also between the dietary magnesium intake and serum magnesium concentration and risk of hypertension. So there 9 studies showed involving nearly 200,000 participants that inverse association between magnesium intake and the risk of hypertension is there. So the more magnesium intake, the lesser the risk of high blood pressure would be there. And on average you need 100 milligrams per day increment in magnesium intake was associated with a 5% reduction in risk of the hypertension. So association of low serum magnesium with diabetes and hypertension, you see the Qatar biobank study that is clearly shown, and this was nearly 10,000 patient data which showed that prevalence of subclinical magnesium deficiency was reported in almost nearly 60% of patients, and high intake of magnesium related is associated with a lower prevalence of diabetes and hypertension. So you have got double benefit. Not only the blood pressure gets controlled, but diabetes incidence also goes down significantly. Then, thiazide group of drug have been shown to cause SMD. So subclinical magnesium deficiency is a principal driver of cardiovascular disease and public health crisis. And it has been seen that the many patients who are on other antihypertensive might have got subclinical magnesium deficiency and would cause or result into uncontrolled hypertension. The thiazide group of drugs have been shown to cause those patients who get magnesium deficiency, there the blood pressure response may not be really good. So correlation of serum magnesium level with the blood pressure is in normotensive and hypertensive patients, you can see this is something which shows that the patients who have got level of magnesium which is lower, then those are the patients who have got high blood pressure. There is a very strong correlation. Even if it is subclinical, then also the blood pressure would be significantly higher. So apart from diet, magnesium supplements in the form of capsules or tablets would lead to reduction in blood pressure definitely. And these data clearly shows that compared to stage 1 hypertensive subjects, the magnesium level is lower in stage 2. So there is a dose related response also. The more the deficiency of magnesium, the higher the blood pressure would be. And obviously, because the smooth muscle cell would be more stiffer, calcification in those will be much higher. So oral magnesium supplements decrease the systolic blood pressure in hypertensive patients on otherwise taking antihypertensive medications. So magnesium and cardiovascular disease, a mini review also shows the same thing, and it has shown that the oral magnesium supplement is associated with small but consistent ambulatory blood pressure reduction in patients with mild hypertension, and the reason being that it causes a smooth muscle relaxation and also the endothelial function improves, so probably that would be the mechanism. So magnesium supplement was associated with a better control of blood pressure, improved endothelial function, amelioration of subclinical atherosclerosis in those patients who were thiazide treated, because we know thiazide till now is considered to be one of the good drugs for control in high blood pressure, and especially in elderly where the risk of stroke also goes down. But those patients who are chronically on these molecules would develop deficiency or subclinical deficiency of magnesium and would lead to adverse outcomes. So if you see the effect of magnesium supplementation on blood pressure in individuals with insulin resistance, pre-diabetes or non-communicable chronic disease, this meta-analysis conclusion also shows that magnesium supplementation significantly lowered the blood pressure in individuals with insulin resistance, pre-diabetes or other non-communicable chronic diseases as well. So it has got a widespread implications. It also works on the inflammation. So if you have less magnesium, the inflammation would be more. Probably we could have studied in COVID patients as well, but we don't have much data. So magnesium in MG hypertension, if you see the magnesium supplementation in stage 1, it would significantly reduce not only the systolic but diastolic blood pressure as well. It plays a crucial role in blood pressure regulation by triggering membrane sodium potassium ATPase and releasing intracellular sodium and calcium store therapy and decrease the peripheral vascular resistance. So by any means, if we decrease the peripheral vascular resistance, blood pressure has to go down, and that is what is happening with the calcium in MGHT. So it reduces the vascular tone and the reactivity, and so that the blood pressure gets well controlled. It also improves the vascular smooth muscle tone, contractility by blocking the calcium channel. So this is a vital adjunct in uncontrolled hypertension. So not only for stage 1 or stage 2 hypertensive patients, you can also add on therapy for grade 3, grade 4 patients, and also in patients with resistant hypertension. And we define resistant hypertension as patients who are needing more than 5 antihypertensive treatments. So probably this is something which has to be tried. And then also, and what does the MGHT contains? It contains magnesium bisulfite 500 milligrams plus L-carnitine, cetosterol, niacinamide, and pyridoxine. So all these combinations would do good in this situation, and it helps supports the comprehensive BP control in these patients. So what it does is that it reduces the systolic and diastolic blood pressure, prevents the drug-induced subclinical magnesium deficiency, reduces the adverse cardiovascular risk, and improves the treatment outcome. And there was the study from the Indian center also, and that clearly showed that this study showed that in stage 1 and stage 2 hypertensive 3 months to the study was there, 6 visits were there, and patients were in common garden variety 35 to 65 years of age, male and female. And there also the study objective was to see whether the reduction of systolic and diastolic blood pressure happens. And once daily dose, very convenient, better effective, compliance is also good, and it resulted into what did it show that the blood pressure reduction was significantly better. So the conclusion of this study was that once a day dose of MGHT therapy added to standard antihypertensive regimen for 90 days reduces the blood pressure in patients with stage 1 and stage 2 hypertension, improving the clinical outcome in these patients. So it can be, look at the recommendations for using is uncontrolled hypertension, in resistant hypertension, but its forte is in initial stage, that is stage 1 and stage 2 hypertensive patients, and also secondary hypertension. And obviously it is once a day doses MGH2. So thank you very much for your kind attention.
Thank you, Dr. Viveka, for a very wonderful overview of the placement of magnesium in the present clinical setting. Can I ask you to join me out here? Considering the talk that you have just delivered, sir, you made a statement that serum magnesium does not always reflect the intracellular magnesium. So how exactly would you be placing magnesium in your practice, especially in the light of sick cases, critical cases? Would you be taking that as an alternative to any of the particular drugs, or just adding it to the combination which you are already having?
So I think those who have got high blood pressure, so stage 3 or 4, will be add-on therapy, but those who have got subclinical magnesium deficiency and stage 1 or stage 2 hypertension, they have standalone MGS to the clip, because it has been seen and we have got the data from nearly 200,000 patients that if you treat the magnesium deficiency, even if it is subclinical or borderline magnesium deficiency, the outcome would be good. Now we have to validate in a much larger trial, and obviously the proof of the pudding is that if you see what we call registry of data and see whether it works out. And we have been long wondering that there are a lot of patients who are on different antihypertensive medicines, and especially those who are on diuretics. After a period, they become resistant to that molecule. Then you have to add some other molecule. So probably drug-induced subclinical magnesium deficiency would be one of the mechanisms which is causing this.
The Indian trial, which was done by the company, showed almost double the amount of benefit in terms of systolic as well as diastolic blood pressure reduction compared to what was done abroad. Do you think it is to do with the Indian genes, or it's too early to say? And the second part is that I don't think magnesium still now, at least till date, has been recommended as one of the therapies by any of the hypertension bodies.
Yeah, so I think I fully agree with you that if you look at the guideline wise, it is not there at all. But as I said that, with our experience in, patients who have got severe resistant ventricular arrhythmias and all, it's very well recognized and it's recommended therapy in those situations also. So probably it's not been really looked into as well as it should be. But the intervention trial has really shown that if you improve the subclinical magnesium deficiency, then the outcomes are really, the blood pressure becomes better, the vascular function becomes better. If it shows that the intervention with this standalone or with the addition to other antihypertensive therapy would add value, we need to really look at more and more data. But this is something which has added interest in that direction, and we must further investigate it.
Absolutely true, sir. India seems to do better with certain molecules. Like we know that we have used metformin for decades, and it used to be something like a barrier for the Americans. But now, given their will, they want to put metformin even in the drinking water of patients. Likewise, Indians have done very well with molecules like cilnidipine, olmesartan, which was hardly recognized in the West. So maybe we have an avenue which might be adding on to the armamentarium of blood pressure medication, and I think Indians should do well. So I am opening the forum for discussion. So let me ask Dr. Mangla sir for his questions.
Well, Dr. Viveka, I heard the importance of magnesium. To my knowledge, we were using magnesium in ICUs for resistant hypokalemia. And we understood that if there is a potassium is not getting corrected, we'll do the calcium, and if the calcium is also low, we'll give a shot of magnesium replacement and the potassium gets better. But since it has a role in the control of hypertension, very important to know that. what I want to say that a lot of patients are on diuretics, even in your practice or in CKD practice. But usually this magnesium replacement is not a part of prescription, as I see. This was just one point to say. I wanted that, there was a statement that what is the most important cause of secondary hypertension. And one learned colleague said the most important cause of secondary hypertension is still primary hypertension. So what would you say when to investigate a patient for secondary hypertension?
Yeah, so I think any hypertensive, I would say, is that deserves full investigation to rule out any secondary cause of hypertension, because sometimes the secondary hypertension could also manifest late in the life. So people say that those who are young patients, we should always look for secondary hypertension or any treatable cause of hypertension like renal artery stenosis, coagulation of aorta, or things like that. But I would say that any patient who is coming at any age, we should thoroughly investigate them for what is the cause of hypertension. Is it just primary hypertension or what we call idiopathic, or it is cause of effect of something. So now I think today's thing has shown that if we look at the subclinical magnesium deficiency also, then probably that will add value. I fully agree with you that in ICU setup the role of intravenous magnesium is very high. So in most of the desperate situation you latch onto this and give our patients this. And definitely the cardiac arrhythmia patient also in ICU setting we take help of intravenous magnesium. So if you look at the secondary and primary hypertension, I would say that investigating all these patients for reversible cause which can be treated. You can treat the renal artery stenosis, you can treat the coagulation of aorta, and the hypertension can go away. So I think everyone should be investigated fully.
Anyone who is Doppler studies are done and you find there is a renal artery stenosis, is there a role of stenting? As I have seen, one of the patients was stented and ended up with a blockade and the renal infarction. So whether these patients are to be still controlled on drugs or there is a role of stenting?
Yeah, so I think this is something where there is a role of, so we need to prove the cause effect, and if the renal artery stenosis is there in a patient who has got kidney which is viable, then definitely there is so we take help of DTPS scan and see if the DTPS scan is suggestive of that, then probably you should intervene. We have also seen atherosclerotic renal artery stenosis. So in elderly patients, we have many patients who have had flash pulmonary edema because of the accelerated hypertension, and their intervention has really helped. So I would say that not all patients, but select few patients would have. So we go by the resistive index of the renal artery, renal parameter on top of the RI is more than 18, then we should be intervening.
Do you often...
Just a small comment, sir. In terms of screening for secondary hypertension, if you have a young patient, especially very severe hypertension with no apparent family history, and you're doing an examination, unequal pulses, must investigate.
Arthritis, yes.
Absolutely, sir.
How often do you find the cause hyperaldosteronism, primary hyperaldosteronism, as a cause of hypertension? And how do you pick it up?
So basically, it's more on in patients who have got it's more of a when you change these patients for primary hyperaldosteronism. So it's mainly we usually in patients who are relatively younger and has got over body weight and all, then we say that okay, we need to investigate. And when we do that, so it's not something which is very commonly picked up. It's something which is not very commonly picked up in usual scenarios, and we need to really, so what we do is that we say that okay, let's get an endocrine opinion, get the battery of hormone assays and all, and then see.
If you find a low potassium with unexplained reason,
Response to spironolactone, you give aldosterone,
Spironolactone,
and the blood pressure just crashes down.
first thing is you have to suspect it.
Yes,
no?
yes, and it's very
When there is
common.
no
So
history,
basically, if you look at the labeling of the what we call resistant hypertension, then the guideline is that
before labeling a patient as resistant hypertension, you must give a trial of spironolactone. If you have not given, you cannot say that it is. So you're right that the pickup rate, so I would say that the prevalence and incidence is higher, but the pickup rate is lower because of the ignorance.
This last question, you see, it is very commonly said, resistant hypertension, obstructive sleep apnea is an important cause. But then if the patient has a resistant hypertension, and he does not give any history of EDS or features suggestive of obstructive sleep apnea, do you advise polysomnography in such patients?
Yes, I think so first of all, we always say that, okay, the history of snoring and all those things are there, but you're right that the patients who have got the two things which is very common in patients who have got obstructive sleep apnea is uncontrolled hypertension, and second is that conduction blocks. So there is a study from Europe which shows that if you treat the obstructive sleep apnea, there is 40% reduction in pacemaker implantation rate in these patients and almost 60% reduction in pill burden for hypertension. So you're right that we should be, so we usually choose the patients who are on the body mass index is high, those who are obese, and those who got a strong history of snoring, then we suspect that the patient would have obstructive sleep apnea. But let me tell you that it's a misconception that only obese people would have obstructive sleep apnea, and that misconception has to be broken. And you're right that one of the battery of tests for hypertension for secondary cause, we should do the the sleep study as well.
I have personally seen that people who had obstructive sleep apnea and were on 4 drugs of antihypertensives and post CPAP therapy, they were just controlled on very low doses of.
We are very right.
So any history of sudden cardiac death in the family, would you want to screen?
History of sudden cardiac death in the family, especially young patient, would you want to screen for sleep apnea in such patients?
Yeah, so I think the battery of tests would include sleep apnea, sleep study as well, apart from the Holter and Holco and maybe this study.
How serum potassium level, low serum potassium level leads to the secondary hypertension. Low serum potassium level leads to the secondary hypertension.
Yeah. Dr. Tulsi, sir.
Okay, so just 4 questions or 4 comments probably. When you're talking about uncontrolled hypertension, SGLT2 inhibitors, MRAs, magnesium, and the renal denervation therapy. So, Dr. Viveka, are SGLT2 inhibitors the new hypertensive drugs?
The answer is yes. Definitely work as an antihypertensive agent, and it's a very good add-on therapy for uncontrolled hypertension.
Right. So the confidence trial and the Fiona trials presented in the European Society of Cardiology just 10 days back. Breaking data presented concluded that EMPA, when added to the new non-steroidal MRAs like phenylalanine, reduced kidney progression and sudden cardiac death in diabetic kidney disease. Sir.
Yes, I think that's a very good observation, and we have seen that when you add SGLT2 inhibitor with MRA antagonist, and we were part of the phenylalanine intervention trial at Max also. And I think it's a very good data that not only the blood pressure gets well controlled, the progression to end-stage renal disease also gets controlled.
And the incidence of sudden cardiac death also reduces. The Fidelity trial was also presented, and they said, you see, it received a thundering applause when the phenylalanine study was presented. Significant reductions in albuminuria and again sudden cardiac death. Minimal hyperkalemia and significant anti-inflammatory and anti-fibrotic effects were seen. So just a word on the Fidelity trial, on the non-steroidal MRAs.
Yes, I think that's the way to go about, because the MRAs have got huge potential. If you see whether it is any cardiovascular disease, whether it is or hypertension, it has been really shown to show the wonderful effect. And with the Phenomenon, it has come into so on. So non-steroidal MRAs are really to look forward to, and I think it is going to be something which is going to be very, very strongly adopted in our practice because of its vast.
Just a paradox, in the Emperor Preserved trial, the effects of EMPA in reducing heart failure hospitalization were more pronounced when MRA non-users were there as compared to the MRA users. Sir, was it because...
So obviously it was getting masked with the MRA.
Right. So now a new study, the Diamond study presented, talked about hyperkalemia with ACE, ARBs and MRAs. So the newer potassium binder, the petromovir, can be added even in severe CKD, heart failure and liver failure too. This is a significant pharmacological advance in the treatment of hyperkalemia, sir.
Yes, I think you're right that this is going to be the future where we don't have to worry about, because a lot of our patients who have got CKD and liver disease, they get deprived of these wonderful molecules. Now the data says that you can keep on washing out the potassium and give this molecule to get them the benefit.
Right, sir. My last three questions. The European Renal Association published its editorial and said MRAs cause hyperkalemia across all strata of kidney impairment, but the subsequent 30-day mortality was lower with the use of MRAs as compared to non-MRA, non-users in DKD. So the renal protective effects of MRAs probably outweigh the hyperkalemic risks.
Yes, I think the benefit which you get from MRA is huge, and when the risk of hyperkalemia is hardly 4 to 5%. So I think MRA is the molecule. It is an unsung hero, I say, that because of its low cost, if the probability cost will go up and it will again become in the front line.
So when we talk about hyperkalemia, hold on. When we talk about hyperkalemia,
this indication till now has been for only the steroidal MRAs, not for this. It is just in an experimental stage.
Non-steroidal MRAs,
only Phenomenon is.
that is a non-steroidal. You said steroidal.
The indications and the recommendations are only for the steroidal MRAs, which are spironolactone and epinephrine.
Magnesium finally affects, lowers blood pressure by modulating the vascular tone, as you said, and reactivity. Acts as a calcium and channel antagonist as well. It stimulates production of prostacyclins and nitric oxide. So, however, there is inconsistent and inclusive evidence right now. What do you say, sir?
Yes, I think we need more data to say something.
So, finally, sir, regarding RDN, so hopefully RDN won't be treated as either the holy grail nor as a global crafty deception. What do you say, sir?
Yes, I think it is getting a resurgence and probably it will come to be used in appropriate patients.
Thank you, sir.